Great. Welcome everyone to this webinar. What we're going to be talking about today is how community health centers can take action to prevent or delay type 2 diabetes. And we're super happy to be doing this webinar in partnership with the National Center for Farmworker Health. They've been involved in a lot of our diabetes prevention and care work, and we're happy to share some of our knowledge of the diabetes prevention program and some of the great work that we've done together with you all here today. So my name is Angela Forfia. I am indeed the Associate Director of Diabetes Education and Prevention Programs. I work at the National Office of ADCES here in Chicago, Illinois. Whereas I shared in the chat, it's 44 degrees and cloudy here today. So maybe it's a little warmer or sunnier where you are. In my role as the Associate Director of Diabetes Education and Prevention, I do a lot of work here. We do trainings, we provide technology, we do technical assistance, all to advance diabetes prevention and care and to get that prevention and care to more people in our communities. So that's why community health centers are such a great partner for this work, as we'll talk about in today's webinar. So at the end of today's presentation, you will be able to describe the National Diabetes Prevention Program, talk about community health centers in your particular community health center as an important care setting for people with prediabetes, that you're seeing these individuals within your health center. We're going to talk a bit about how diabetes prevention programs advance the quintuple aim for community health centers. And as we wrap up today, we'll talk about opportunities for you to activate successful and sustainable prevention programs in your health center. So let's start by I'm going to start by talking about the quadruple aim. We will add one more piece of this aim on the next slide. If you've been working in community health or population health or public health or healthcare in the past, 10 or 15 years, you have probably seen the quadruple aim. And what the quadruple aim is about is just reminding us that all of these pieces of the healthcare puzzle, all of these pieces of this cycle are connected. So a lot of community health centers, they have this kind of population health approach baked into everything that they do. When you're serving your community, you're thinking about the risk for type 2 diabetes, for heart disease in your community. You're thinking about adding screenings and providing this preventive care and providing chronic disease prevention. So you always have a mind of looking at your overall patient population and then looking at all of those patients together in the population that you serve within your health center. Everyone is mindful about reducing costs. We know that these complications and conditions are expensive. Type 2 diabetes is one of the largest contributors to healthcare expense at every level. If individuals have type 2 diabetes, they bear a lot of costs, their families bear a lot of costs. It affects our communities if individuals have these complications and they're not able to work or support their families. We bear a lot of costs collectively through Medicare and Medicaid programs. And this just really has a tremendous cost even at the health center level as you're supporting these individuals with type 2 diabetes. It's also important to think about you and your colleagues on the care team. If you're working with an individual and you've been talking to them every time that they've come in about, let's look at your eating patterns, or let's look at your physical activity. Are there ways you can add more movement to your life? Are there ways that you can lose a modest amount of weight and help keep that weight off? And that individual might be, during the visit, very interested in making those lifestyle changes, very interested in moving more, being more active, eating healthy, managing stress, sleeping well. I mean, who on this call is not interested in those things? But without that support outside of that office visit, it's going to be really hard for that person to do. So if you're their nurse practitioner, or you're their PA, or you're their doctor, having them come back, it's like, oh, we talked about this last time and we really weren't able to kind of activate anything because these lifestyle changes are hard. On the other hand, if you are that patient, if you are that individual, and you're like, yeah, my nurse practitioner has a 5-minute conversation with me about, sleep and stress management and how to lose weight and what to eat and how to be active. And it's like, I need more support than this. I don't feel like my providers have enough time for me. And so all of this kind of fits together in this idea of the quadruple aim, that if you want to affect the health of the population, if you want to reduce costs, you want to have your care team feel excited to come to work and feel fulfilled by their work, you want to have your patients feel like they're being supported, you have to kind of bring all of these pieces together. And then, it took us a while to kind of build this quintuple aim. We started out with the triple aim where we're like, yeah, if patients are having a better experience, then we get better outcomes and we can lower costs. And then it took us about 7 years, and we're like, you know, actually our healthcare team matters. We matter too. That it helps that if we have a sense of well-being, that if I have to put on my own oxygen mask first, if I feel like I'm supported, then I can provide better care to the people that are coming to me, whether I'm a lifestyle coach, or a pharmacy tech, or a physician, or a diabetes care and education specialist. If I have a sense of support and well-being, I can provide better care. And then it took us another 7 years to say, like, equity is critical to this, because if we're not aware of racism, of poverty, of these structural conditions that are affecting the health of our patients, it's one thing to say, like, hey, you should get more physical activity, or you should eat healthier foods. But what if the person I'm talking to is in a food desert or is in a community where it's not safe to be physically active? So I can't just live in my health center bubble without an awareness of these conditions that surround my health center, that surround my patients and their families, that determine how much they can kind of put this health guidance into effect. And if we're not, looking at things through our equity lens, then we just end up reproducing and recreating some of the same issues that we're trying to fix within the healthcare system. So I'm going to now kind of move from this big picture talking about the quadruple aim and the quintuple aim into talking about diabetes and why this specific work in diabetes matters. So let's start with the kind of big picture in diabetes. As we look around our country right now, we have 37.1 million American adults. That's about 11% of the population who have diabetes, who have, either have a diagnosis of diabetes, or, we're looking at the results of their screenings and we know that they have diabetes, even if they have not been told by their healthcare provider that they do. Under the surface of the water are 96 million American adults. That's about 38% of the population, more than 1 in 3, who have pre-diabetes. And you might be thinking, like, oh, maybe you're sitting in front of your like EHR right now and you're like, well, let me look that up. Who are we seeing in my health center? You might be seeing these 11%, maybe even more, who have diabetes, but you might not feel like you're seeing these other individuals who have prediabetes. But sometimes, the reason this is under the water is this is a little hidden. You may be seeing people who have overweight or obesity, which we sometimes call adiposity-based chronic disease. You may be seeing people with high blood pressure, with high cholesterol, with gestational diabetes during pregnancy, with PCOS, with non-alcoholic fatty liver disease, pancreatitis, sleep apnea, joint pain, depression, and more. So there's a lot of these comorbidities that travel along with prediabetes. And you might want to look in your EHR and see, getting height and weight is something that is happens at almost every visit. So you can look at the body mass index of the individuals that come to your health center. That'll give you some information about how many of the people you see might be at risk for prediabetes and diabetes. You can look at those individuals with high cholesterol or high blood pressure. Those map really closely onto prediabetes. So looking at some of these diseases that sort of point to prediabetes and kind of tell you that those individuals are coming to your health center. As I mentioned on that iceberg slide, about 37 million American adults have diabetes. About 1 in 5 don't know it. They don't know that they have diabetes. The prevalence of diabetes increases with age. So among those 65 and older, so again, you can kind of think about who you're seeing in your health center. Among those 65 and older, about 30% of those older Americans have diabetes. And the prevalence is highest among certain ethnic and racial groups. So it's highest among American Indians, people of Hispanic origin, non-Hispanic African Americans, and some Asian American Pacific Islander groups. Diabetes prevalence is also about 17% higher in rural areas. So sometimes when we think about those health inequities and health disparities, we kind of think about urban areas. But what we really see with diabetes is that it's those rural communities where, again, thinking about that equity piece, those social determinants of health, people have lower socioeconomic status, lower levels of insurance coverage. It's harder for them to access care, especially specialty medical care and emergency services, and there's lower levels of exposure to diabetes education. So now let's turn to prediabetes. Well, prediabetes, I always like to describe prediabetes as a high-risk state for developing type 2 diabetes, heart disease, and stroke. It's a place where, if you do that A1C or that fasting plasma glucose, you're going to see blood sugar levels that are higher than normal, but they're not high enough to result in a diagnosis of type 2 diabetes. The risk factors for prediabetes are some of the same risk factors that we see for type 2 diabetes. Weight status, elevated weight, age. As we get older, our risk for developing prediabetes and diabetes increases. A family history. So do you have a mother or father that had diabetes, a sister or brother that had diabetes? Race, ethnicity, as we saw in the previous slide, lack of physical activity, history of gestational diabetes. So if you have been through a past pregnancy, that's a stress test for the body. And if during that stress test you develop gestational diabetes, it's a sign that you're at risk for prediabetes and also type 2 diabetes and PCOS. So there is a kind of paper risk screening that you can do for prediabetes. It's called doihaveprediabetes.org. That's available in both English and Spanish. And of course, the diagnostic test is the same as with type 2 diabetes. It's taking a simple blood test like A1C or fasting plasma glucose. So all of this basic information about prediabetes you can find on CDC's website. So as I mentioned before, we have 96 million Americans that about 8 in 10 don't know that they have prediabetes. A higher percentage of men than women have prediabetes. So men are at greater risk of having prediabetes. So again, when you're looking in your electronic health record system, you can kind of, slice and dice that data and sort of look at who the men are that are coming to your health center. The prevalence of prediabetes is pretty similar across different racial and ethnic groups and education levels, but it's really who develops type 2 diabetes from there, who kind of tips in to type 2 diabetes. And just as we talked about with diabetes, prevalence increases with age. So we talked about how, over the age of 65, about 30% of those individuals had diabetes. Almost 50% of seniors have pre-diabetes. But more than 20% know their status. So they're going to see their healthcare provider regularly. They're getting those yearly tests. And so they know that they have prediabetes and they're more ready to take action on that information. And if you are interested in this data like I am, you can find all of this information on CDC's website as well. So if you're, thinking to yourself, it's like, well, I definitely see a lot of people who have overweight or obesity. We have a lot of patients who have high blood pressure, high cholesterol. We see people who are pregnant, who develop gestational diabetes. Maybe I should start screening my patients for prediabetes, or maybe I should even screen myself for prediabetes, or maybe I should take some of these to my holiday gatherings and pass them out and, see how the rest of my family is doing. The good news is it's easy to do that. There's a great website. It's called doihaveprediabetes.org or doihaveprediabetes.org/ES for the Spanish version, which I've put up here on the screen. And it allows you to take this little test online. It's very easy to do. You can do it in less than a minute. If you want to have something that you can give to patients in your waiting room or, have your medical assistant, work, or your community health worker or promotora go through with your patients, you can get a printed copy, either in English or Spanish for that. And there's lots of resources that are connected to this campaign that you can, like if you have a little video in your waiting room, or if you have a place that you can share information on your patient portal, there's a lot of resources that are connected to these little tests. So the good news is, as a community health center, you are already seeing people with diabetes, prediabetes, other cardiometabolic conditions like cardiovascular disease, like overweight and obesity. Many of you are probably already screening or testing the adults that you see. You might already have those fasting plasma glucose tests or those A1C, and you're identifying some people who are at risk. Even if you haven't had them fill out that little survey, you might be able to figure out from their other health conditions that they're at risk for developing type 2 diabetes. You're seeing a wide variety of people. Maybe some of you have that maternal care program where you're seeing, and pediatrics program where you're seeing little kids and you're seeing them all through their lifespan. And you already know, you're already committed to population health. You're committed to preventive care and primary care. You understand the communities that you're working in. And you also know how to coordinate care. You realize that you as a community health center can't do it alone. You're not going to have every sophisticated test in the world within your community health center. So, we sometimes talk about a medical home, but I always like to think about a medical neighborhood, like Mr. Rogers' neighborhood, that you have, like, oh, there's someone who needs advanced care. I can refer them out and know they're going to come back to me for that primary care, or they need this additional support. I can send this person out and then reconnect them. So as a community health center, you are perfectly positioned to do this work. And there's even better news for you. There's a really great program that helps prevent or delay type 2 diabetes, and it's called the National Diabetes Prevention Program. So that brings us to our first little poll. So it says, where do you know? But I think this is supposed to be, what do you know about the National Diabetes Prevention Program? Although maybe it's where, like, where did you find out? So there's going to be a poll that pops up for you. You can answer one of these things. I know a lot about the national DPP, but I have a few questions. I know something about the national DPP and I want to learn more. I know a little about the national DPP and I want to learn more. Or I haven't heard about this national DPP thing. What is it? So just take a moment and click the answer that sounds most right to you today. And let's see if we can get everyone to vote. Get 100% voter turnout on this poll question number 1. And then if you have anything else that you want to share, like where you heard about the national DPP or your experience, you can always drop that in the chat because I have that pulled up on my screen too. So that can provide some additional qualitative information. All right, did everyone have time to vote? I'm not really seeing the results come in, so I like you, I'm gonna have to wait for these results to be shared in anticipation. Wow, this is like a really kind of evenly divided group. So we have about 18% of the folks on this call who know a lot about the national DPP. So yeah, definitely like drop that in the chat. Feel free to share some of your thoughts when we get to the live Q&A at the end. About 20% know something about the national DPP, want to find out a little bit more. 31% know a little, and then another 31% haven't heard about the national DPP. So like I couldn't have created a better group for this webinar. This is like the perfect group. You are all in exactly the right place to learn a little bit more or learn a lot more about the national DPP. So thank you so much for joining today. So what is the National Diabetes Prevention Program? So I'm going to walk through some of these slides to kind of give you the history of this program and where it is today. So the National Diabetes Prevention Program started way back in the 90s. It really is way back at this point. From 1996 to 1999, and there were 27 different clinical research centers across the country. They recruited more than 3,000 participants, and they over-recruited participants from what we call now priority populations or populations of concern. And these were groups that were identified as most at risk of developing type 2 diabetes. So 20% of the folks in the study were over the age of 60. About 70% were women. It was there were more women than you would expect even at the beginning of this program. And 45% were from different populations that were at higher risk for developing type 2 diabetes, like African Americans, Alaska Natives, American Indians, Asian American Pacific Islanders, and Latinos. All of the participants in the study had overweight or obesity and all had impaired glucose tolerance, which we now call prediabetes, but actually impaired glucose tolerance was a little bit bigger than prediabetes. So some of the people that were in this original study, if we diagnose them today, would already have type 2 diabetes. So it was a very diverse group of people that went through this study. And they divided these individuals, these 3,000 individuals, into one of 3 treatment groups. One group got a placebo. So this is, they got their prescription for these pills, but the pills had no medicine in them. So these were just kind of like pills that, had nothing that they were trying to study. And they got some brief lifestyle counseling like, hey, you should manage your stress. You should get a little bit more sleep. Why don't you lose a little bit of weight? And they got this placebo prescription. Another group got that brief lifestyle counseling, but they got a medication called metformin, which is used today for people that have type 2 diabetes. They were kind of trying it out in the study to see if it had an effect to prevent or delay type 2 diabetes for people who had prediabetes. And then the final group got intensive one-on-one lifestyle support. So they worked with a doctor or nurse or pharmacist, and that person helped them every step of the way for a whole year, figuring out, how to eat healthier foods, how to sleep a little better, how to manage their stress, how to get more activity, how to connect with support in their community. So what we learned from this work is that the placebo was not helpful at all, but the people that received this intensive one-on-one support, um, they were able to they were able to reduce their risk for type 2 diabetes by 58%. So that was the general group was able to reduce their risk by 58%. And those over the age of 60 actually reduce their risk by 71%. So this is one of, there's not very many interventions that the older you get, the more successful it is. So those who were older actually had an even bigger impact on them. Now, this metformin medication was also shown to be effective. It was most effective with younger participants, women who had a history of gestational diabetes, and those who had higher weights going into the study. So it was supposed to be a 5-year study. They actually only did it for 4 years because they're like, wow, this DPP group that's great. We need to roll that out for everyone. So they rolled out that diabetes prevention program for everyone. And then they followed this group of people over time. So even at 10 years, when there was, some people gained a little bit of the weight back, they weren't in the most intensive part of the program, they still had reduced their risk for type 2 diabetes. And even at 15 years, they had a 21% reduction in risk. And it was only when you got out to 15 years that you started to see, metformin is about as successful as the diabetes prevention program. So really, really successful program. What we learned through that study is that weight loss is the most important factor in reducing risk for type 2 diabetes, and it had the same positive effect across all of the populations, whether you were young, whether you were older, whether you were different racial or ethnic groups, regardless of these other risk factors. And the good news about weight loss is you don't have to lose, 100 pounds to have a big impact. For every 2.2 pounds of weight loss, the risk of type 2 diabetes decreased by 16%. So this is not a huge amount of weight. What we were shooting for in the DPP study was about 5 to 10% of your starting weight. But magic things don't happen at 5%. Every little bit of weight that's lost results in reduced risk for developing type 2 diabetes. We also learned that physical activity really matters for weight loss maintenance. So again, you go through this intensive year-long program and you were meeting with this doctor or nurse, or today, maybe you're meeting with a lifestyle coach, then that lifestyle coach and your group go away. You need to keep up that physical activity in order to maintain that weight loss. So this was a great program, but as you can imagine, it would be really, really expensive to do this with 96 million Americans. Like all 96 million Americans would be connected one-on-one with a lifestyle coach, and get all of the support. This would be very pricey. So after we did the DPP study, a lot of organizations, including the YMCA, worked to translate this into something you could actually do in your community health center. So they moved it out of the research hospitals into these community settings like your health center, like YMCAs, like churches and temples, like community-based organizations. They also moved it from a one-on-one support system into a group program. So instead of having just a coach talking just to me, they would be talking to a group of 10 or 15 people. They also realized that these trained lifestyle coaches did not necessarily need to be physicians or nurses or PAs or diabetes care and education specialists. Those folks are all great lifestyle coaches, but community health workers and health promoters and promotoras, like they can all be phenomenal lifestyle coaches, and they're able to work within these community settings, and they're often more trusted within these community settings than sending somebody off to a big research hospital in the big city. Diabetes prevention, later we learned, can be offered online or through distance learning. We're doing distance learning right now today. If you're listening to a recording, you're doing online learning. So there are many ways for us to kind of get connected with people with prediabetes in our community. So when you put all those things together, it really allows this to be a type of intervention, a type of program or service you can offer within your community health center. When they made these changes, they kept some things the same. So we still want to find that population that's at greatest risk for developing type 2 diabetes. I mean, as I said, like everyone could probably benefit from this, especially during, this time of year. It's like, well, maybe I'm not getting as much sleep. Maybe I'm not dealing with stress very well. It's like, maybe I should be eating, should be filling my plate with half of my plate with vegetables. But in order for this program to be most effective, you want to identify that group that's at highest risk of developing type 2 diabetes. This was a year-long program, and although it would be great if we could, do this in a boot camp weekend, we can't. You really need that duration of the program to have people kind of live through this program for an entire 12-month period. You also need a pretty intense dose of the program. So, this program starts off with weekly sessions. So it's like you have 1 hour every week for the first 12 or 16 weeks. And then it moves into bi-weekly sessions. And then it moves into monthly sessions. And having that dose of about 24 sessions over the course of the year is where you get the best outcomes. And speaking of outcomes, the goal is still that 5 to 7% weight loss and increasing physical activity to about 150 minutes of moderate to vigorous physical activity every week. So that's about 30 minutes most days of the week. So we went through that original study. We learned all of these things as we translated it into community settings. So what does this program look like today? Well, I have a little video to show you that kind of gives you a feeling of what the program looks like today.
If you knew you could change your life for the better in 24 hours, would you do it? The CDC-led National Diabetes Prevention Program's Lifestyle Change Program offers just that, an opportunity to learn new ways to get healthy and prevent type 2 diabetes. It all takes place in 24 one-hour sessions over the course of 1 year.
In the beginning, yes, I did struggle with the time commitment. But 1 year is a very short time compared to the rest of your life.
So many of us are hard on ourselves when we're trying to make a change, but in less than 24 hours, you can change your life. And it's doable. It's very achievable for them.
We're the healthiest we've ever been. We're the happiest we've ever been. And we owe the rest of our lives to the program.
This is a change in life. This is something that will stick with you and keep you better.
Type 2 diabetes can be prevented. Learn how you can improve your health and change your lifestyle in just 1 year. Visit www.cdc.gov/prevent-type2.
Great. And there's a lot of these videos that are on this website that you can see right there. Like I could push play and we would see another video, but we're not going to continue to watch them. So if you would like to access some of these other videos, you can go to this website, which is www.cdc.gov/diabetestv/imagine-u HTML. Okay, it's going to play again, but I'm going to move on. So as you saw in that video, this is what this program looks like today. It's led by a trained lifestyle coach. It's hosted in that small group that I've talked about, and it's hosted in these community settings, like a community or faith-based organization, a federally qualified health center or community health center, a pharmacy, a church, a mosque. Like these are all places that these groups are held across the country. And as you also heard in the video, a lot of these things are the same that we kind of took from way back in the 90s. Sometimes things in the 90s are still relevant today. We have a program that's at least 12 months long. We have this core session of these weekly or biweekly sessions and a core maintenance series where we kind of move from the most intense part of the program to monthly sessions that are moving on. And our focus is this reduction in risk for type 2 diabetes. So 5% weight loss or 4% weight loss plus 150 minutes of physical activity, or looking for those reductions in A1C. So maybe you saw that video and you're like, that's great, but I want to find something that kind of speaks to the people that I work with in my health center. And, not every group looks like this group that, is probably in suburban Atlanta. So there is, on that website, there's a lot of testimonials from individual participants who are sharing their stories and are talking about how they're making changes in their life that are reducing their risk for type 2 diabetes. So here's Denise, who's a young mom who's talking about, how participating in this program gives her more energy and she has more energy to be there for her kids. So now let's turn to talk about community health centers and your community health center and how you can help expand the diabetes prevention program. So why would your community health center want to get involved in this? Well, maybe you're like, of course we do. Or for some of you over in the chat, wow, we already are. We're already making this happen. We have, shout out to Project Vita, who's like, we've got CDC full recognition and we've been working on this for 5 years. This is a no-brainer for us. But maybe you're, still kind of figuring out what to do next. So I'm going to tell you that community health centers are like my favorite place to have the National Diabetes Prevention Program. You're already engaged with preventive care and chronic disease prevention and care. You're effective. You have amazing multidisciplinary care teams. So you have those dietitians and you have those nurses and you have those PAs and nurse practitioners and docs, but you also have your paraprofessionals and your diabetes community care coordinators. You're accessible and affordable. You can engage people in your community, including those that, are uninsured, that, can't access other care. You're trusted and relied upon by people living with diabetes and other chronic conditions, and you're aware of these social determinants of health needs. You don't have blinders on when it comes to the needs that people have in your community. You know about food insecurity. You know about lack of insurance, of people having a hard time affording medication. You know about housing issues, transportation. So it's something that's kind of built into the work that you do. Now, as we talked about, there's lots of community organizations that can do the diabetes prevention program. Church, I have a little church here on my slide. Churches are great. They are also trusted. They are also accessible. They are also embedded in their communities. They also have a lot of time with community members. And, certainly hospitals and large health centers can do the diabetes prevention program. They're also trusted. They collect health data. They're aware of these other conditions and medications. They have their EHRs that they can look these things up. They have their patient portals, and they see people facing these acute health challenges. But, my church usually doesn't have an EHR. They don't know about some of the things that are going on, and they might know about my spiritual health, but they might not know about my physical health or things that are going on with me, what medications I'm taking. I don't think so. And hospitals, I might go there for acute care. I might go there to see a specialist, but I'm probably not going there regularly in the same way that I'm going to a community health center. So community health centers are really the best of both worlds. You know, you are accessible, you're embedded in these communities, you have time with community members. I know that none of us feel like we have enough time with our patients or enough time with our community members, but you have more time maybe than an emergency department. And you are collecting this health data, you know, unlike my church, you're collecting health data, you're aware of these conditions, and you're also seeing people for both acute and chronic care. So let's think a little bit about the people with prediabetes that you're seeing. You know, as I mentioned, people with prediabetes may be overrepresented within your community health center. You might be seeing individuals with overweight or obesity. Again, you can look up those BMIs. You may be seeing people with sleep disorders or joint pain or reflux. You could be seeing people with high blood pressure, high cholesterol, all of these other comorbidities, these kind of fellow travelers with prediabetes. Um, and maybe somebody got care somewhere else. Maybe they went to the hospital, they had an A1C done, and you know, someone said, "Hey, you have you know, as long as you're here being treated for your broken leg, you also have prediabetes." And then they have to follow up with you to get that ongoing care. Or maybe they've seen a specialist and then they come back to you for that primary care. So these are all of the different folks that might be finding their way to the door of your community health center. So, what are some things that you could do as a community health center? One is that you can work to increase the identification of individuals with prediabetes in your system. Like I said, you know, you probably could sort of see between the lines of who has prediabetes, but you may not be doing these screenings routinely for everyone that you're seeing within your health center who would qualify for fasting plasma glucose. You might not be doing this paper screening for people sitting in your waiting room. Helping to kind of reduce or reframe this idea, and this idea is very prevalent of like, you know what? My dad had diabetes. What can I really do? Is there anything that I can do that's going to prevent me from having diabetes? You know, like my brother has diabetes, my dad has diabetes. Doesn't that mean that I'm probably going to get it too? Like what can I really do about that? What is this pre-diabetes? Does that just mean like, hey, I have one sign on the road and the next stop is going to say diabetes and there's no way for me to get off that road? There's nothing I can do to kind of change my journey. So like reframing that and saying, no, we actually have this program that can reduce your risk by, you know, almost 60% or 70%. This isn't something that has to happen. This is a place where you can take action and you can have a different experience. So kind of reframing some of those thoughts about diabetes. And of course, supporting people as they activate lifestyle change. None of this stuff is easy. You know, this like how many years have you been eating food, you know, since you were 6 months old or, you know, 9 months old? And, you know, you have to change those ways of eating, those kind of patterns that we've worn in our life about how we eat, how we're being active. So all of those things are things that you can do, if not tomorrow, very soon. You know, you can think about how to do these things. Something that's a little harder is to say like, okay, well, now I know who has prediabetes in my system. You know, I'm having positive person-centered conversations with them, motivational conversations with them. I'm supporting them when they come into my health center. Maybe I've started a walking program. I've started a gardening program. But now I want to actually get them into the National Diabetes Prevention Program. So, you know, you could do that one of two ways. You could refer them to a program in your community, or you could start your own program. We have some folks in the chat box that are like, I started my own program. I've been doing it for 5 years. But maybe you're not ready for that. Maybe that's a little like, makes you a little anxious. There are programs that are available out in your community. And even if you send them out, you know, in your medical neighborhood to one of those programs, they're going to come back to you for primary care. So you're going to have a chance to support these individuals moving forward as they're changing their eating habits, changing their activity habits, managing stress, developing healthier sleep hygiene, as they say these days. So, what are some ways to activate prevention in your health centers? Well, one of the ways is just to raise awareness about prediabetes and raise awareness about the diabetes prevention program. This could be posters or handouts or videos or social media. It could be patient portal announcements. Maybe you are handing out those paper screenings and promoting some of the programs that are in your community. Every single program that we work with is like, oh man, I'm trying to start a group and I only have 3 people that have signed up. They want the people that you're seeing within their health center to sign up with those programs. And so many of those programs are free or low cost or supported by grants that, you can kind of send people to those programs and they can get connected. Initiating positive conversations with individuals who are at risk, screening and testing, referring, and again, the biggest step would be starting your own. So if you want to refer, just know that as a community health center, your care team plays a really important role in diabetes prevention. You are the first one that probably talks to someone about this diagnosis. Your guidance really matters. The fact that you're saying like, no, this isn't just a one-way ticket to diabetes. There are things that you can do that will help you live a longer and healthier life. And we also have research that shows that if I'm a nurse practitioner and I'm talking to one of my patients that is a patient that I've seen for 5 years or a year, and I say like, hey, this is what we found out. This really matters to me. I think this program would really benefit you. You're gonna connect with Maria. She's an amazing lifestyle coach. You should go find her and let me know how this program goes. Here's all of the information. I'm also, with your permission, I'll let Maria know that I'm, shared this information with you. That really matters. Those people are more likely to go, to get engaged, and to achieve those outcomes that actually prevent or delay type 2 diabetes. You don't need a paper referral. You don't need a fax form. But your quality referral of saying that this program matters, this program is effective, that's what makes a difference. As I said before, lifestyle change doesn't happen within a 15-minute visit or a 30-minute visit. People with prediabetes need that ongoing support so they can develop these behaviors over time and face the barriers that they have to make those changes and overcome them. But your healthcare center is still needed. They're going to come back to you. They might need additional care. Like if they're experiencing, this is not a shocker, but if someone is experiencing clinical depression, it's going to be really hard for them to go through a 12-month lifestyle change program. They're going to have to work on the depression first before they kind of have the capacity to do that. They might be experiencing sleep apnea. Although the DPP will, help with part of that, they may still need that support to deal with sleep apnea. That's a very serious condition. They may need additional support on obesity treatment that's outside of the diabetes prevention program. So you might be thinking, well, this is like, I don't know any of this. This is all new information for me. One of the things that you could do right now is you could go to the CDC's website and try to find a program. I put the direct link in here. I usually just go to Google and I'm like, find a diabetes prevention program, and it takes me to this site. And I put in Buda, Texas, because that's where the National Center for Farmworker Health is. But you could put in your current community, your hometown, and see what's available to people within that area for diabetes prevention. Maybe you have been so inspired by this webinar that you're like, I want to start my own program. And I want it to look like this, all of these like super engaged people who are, benefiting from this program in their community. So what I would say to you is get leadership support, go and try to rally your team, try to find some people that are willing to work with you on this. Think about how the work that you're already doing can support diabetes prevention. You don't have to like reinvent the wheel. Maybe you have someone who would be a fantastic lifestyle coach who's already doing a lot of that health education work. Maybe you have some adjacent programs that can really support diabetes prevention. Think about your patients and your community members. CDC has a great capacity assessment that allows you to go through and, answer honestly and think like, well, I have this, but I don't have this. So you can kind of create a roadmap for where you want to go with diabetes prevention. And, you don't have to go from 0 to 100 overnight. Find a program and a plan that's the right size for your organization and get help. You do not have to do this alone. Maria is going to drop some links over in the chat. The Centers for Disease Control, their diabetes prevention team has a lot of resources. ADCES has a lot of resources. NCFH has a lot of resources. Some of these resources we've worked on together and they are available to you. We have resources in English. We have resources in Spanish. CDC has resources in a wide variety of languages. So we're very happy to help you on this journey. As you know, we started off today talking about the quadruple aim and the quintuple aim. Diabetes prevention is a really valuable, can be a really valuable part of the services that you provide. Not only does it increase revenue to some of your other services, it helps you meet these pay for performance metrics. It creates and sort of reinforces your center as a medical home, supports population health and health equity outcomes. It also allows you to achieve this quadruple aim. By moving upstream, you're getting better outcomes for your population. You're reducing costs, you're eliminating some of those really expensive complications, and you're lowering the cost to provide that care within your community. Your care team also feels better. Instead of just having the same conversation with Mr. Landry year after year after year, you can say wow, I referred Mr. Landry to the National Diabetes Prevention Program. He came back a year later, he's lost weight, he's reduced his blood pressure and his A1C, he's taking his medication. I was even able to take him off of medication because of all of these lifestyle changes that he's done. And that makes your care team feel better. And it certainly makes Mr. Landry feel better. Not only is he coming to see his, physician assistant in your practice, but he's also getting the support from this lifestyle coach. So we're almost at the new year, which is the time for New Year's resolutions. So I'm going to ask you to make a national DPP resolution, and that's our next poll. So are you going to talk to your team about diabetes prevention? That's a pretty, just have a conversation, maybe go over and refill your water and you're like, hey, I just went to this webinar on diabetes prevention. Let's talk. I'd like to put this on our agenda for our next meeting. Are you going to think about what's in your community and start referring patients to a diabetes prevention program there? Are you going to start your own diabetes prevention program? That's a pretty big resolution, but you're like, we can do it. We've been kicking this around a while. Or you might want to learn more about the diabetes prevention program. It's like, I'm gonna learn more first. And for some of you over in the chat that are like, yeah, I've been doing this for 5 years. Maybe you have an even more ambitious, we're going to enroll 80 people this year in the National Diabetes Prevention Program, or we're going to bill Medicaid for the National Diabetes Prevention Program. So you can go ahead and drop your New Year's resolutions over in the chat as well. So I'll give you just another second. All right, what are our resolutions? Talking to your team about diabetes prevention, always a really great place to start. Referring patients to diabetes prevention, man, take a look at that map and see what's going on in your area. You might be surprised at how much prevention is happening all around you. Starting your own diabetes prevention program, we have one person who is making that commitment. So please follow up with me and with Maria and ADCES and NCFH, and we will help you. And then about a third of you want to learn more about diabetes prevention. So again, all fantastic national DPP resolutions, and we're here to support you as you take those next steps. So here are some resources and references for you as you get started. The CDC's DPP Customer Service Center has a lot of resources. Definitely check that one out first. There is that doihaveprediabetes.org. There's statistics if you want to find out more about what diabetes looks like or prediabetes looks like in your state. There's all of those videos on Imagine You Preventing Type 2, and there's that map where you can find a DPP in your community. So this concludes today's webinar. And if you are joining us live and in person for some distance learning, we are going to have a live Q&A. So stay on for the evaluation and this live question and answer. And otherwise, this is the end of our recording. So thank you.